Welcome, awesome staff at the Northwest Kidney Center with a special acknowledgement of our flagship unit in Kent, and this month to our friends at the Rainier Beach unit. This is the holiday edition of our monthly dialysis in service, and today I will discuss the significance and management of fever in a hemodialysis patient. Of course, we are entering winter season, which is peak time for the development of infections, so I think it's good to review an approach to managing the febrile dialysis patient. Behind cardiovascular disease, infection is the second most common cause of death among dialysis patients, accounting for the loss of about 20% of our patients. So, fever is a common occurrence in this population and something which we will frequently encounter at our dialysis units. There are four objectives of today's talk. I want you to be familiar with the definition of a fever as well as with the history of the development of the thermometer. I want you to understand the clinical significance of fever as well as have an approach to management options. Let's begin by defining our terms. What is a fever? The word fever comes from the Latin term febris, meaning fever. In contrast, pyrexia, you may have heard, for example, of an antipyretic. Pyrexia comes from the Greek word pyre, meaning fire. It's an elevated body temperature caused by a regulated upward shift of the body's internal set point, which is controlled by a part of the brain called the hypothalamus. It is part of the body's immune response or defense mechanism. A normal body temperature ranges typically between 97.5 degrees and 99.5 degrees, but there's considerable variability both within an individual as well as between people. Temperature above 100.4 is generally considered a fever in adults. Temperature of 101.5 is generally classified as a serious fever. We start to see multi-organ failure when the temperature reaches 107 degrees. The highest recorded temperature in a human was 115 degrees, and that was in a patient named Willie Jones, who at the age of 52 in 1980 was admitted to Grady Memorial Hospital in Atlanta with a heat stroke. Now, technically, that wasn't actually a fever, and I'll discuss this in a second. He just had an elevated body temperature because of heat stroke, but still, that's the highest recorded temperature. He was in the hospital for over three weeks, and he did survive that illness. So, how exactly does the brain cause a fever? Well, the body gets exposed to some sort of infection or external stimulus, something to rev up the immune system. The immune cells then release chemicals called pyrogens. These are chemicals that raise the body temperature and include various hormones such as interleukin 1, interleukin 6, TNF alpha, tumor necrosis factor alpha. And these then increase the activity of something called cyclooxygenase enzyme in the brain, which leads to the production of brain prostaglandins, which triggers the firing of neurons that control temperature in the hypothalamus. The hypothalamus then raises something called the set point. That's the temperature set point. So it will set the target temperature for the body at a higher temperature. So, for example, 101 degrees rather than 98.5 degrees. The body then produces heat through shivering and tightening of blood vessels called vasoconstriction until it reaches the new target temperature or the new set point. So the set point is a temperature your body is trying to achieve. A high set point makes a person feel cold, and again leads to muscle contractions and heat production. When the set point returns to normal, a person then feels hot, becomes flushed, begins to sweat, and that's what we say when someone's fever is breaking. As I mentioned earlier when discussing the case of Willie Jones, an elevated temperature, of course, is not always a fever. So, for example, if you exercise, you increase your body's temperature. It's only a fever if the hypothalamus has raised the body's temperature set point. An elevated temperature in the absence of an increased set point is just called hyperthermia, and that's what we see, for example, with exercise or with a heat stroke. Everything in life has a purpose, including fever. The purpose of fever is to slow the growth of viruses and bacteria that may be causing an infection. Fever also enhances our immune cell function and generally signals that something is wrong. We feel bad, it makes us drink water or seek medical attention. Fever is one of the most common medical signs. 30% of healthcare visits by children are for fever. 75% of adults who are seriously ill have a fever, and 5% of all emergency department visits are for a fever. Okay, just for fun, let's switch to the next part of the talk, which is a discussion of the history of the thermometer. Like most of medicine and frankly modern society, it all began with the ancient Greeks, including Philo of Byzantium, Hero of Alexandria, who basically experimented with air expansion and water displacement. So they discovered that air can expand and contract, and if you filled a tube partially with water, the water level can change depending on whether the air is expanded or contracted. Of course, they had no way of measuring temperature back then. All they knew is that air could expand or contract. And it wasn't until the 16th century they discovered that the temperature of air was what controlled its expansion or contraction. The next big breakthrough in temperature measurement came with Galileo Galilei, who, as you all know, is a famous Italian astronomer, physicist, engineer, philosopher, mathematician, and inventor. And he played a major role in the scientific revolution of the 17th century. For example, he championed something called heliocentrism, which is the astronomical model in which the sun is at the center of the solar system and the Earth and other planets orbit around it. In 1593, Galileo invented something called a water thermoscope. This is a container filled with bulbs of varying masses, each with a temperature marking. And the buoyancy of water changes with temperature, so some of the bulbs sink while others float, and the lowest bulb indicated what the temperature is. So essentially, it was a thermometer without a scale. It could show that something was getting hotter or cooler. And so for the first time, it allowed temperature variations to be measured. But of course, there were limitations. There was no scale, there was no standardization, and it could be affected by atmospheric pressure. The birth of the thermometer came in the 17th century. Santorio Santorio was an Italian physician. He's credited with adding a numerical scale, which made the device more useful in medicine. Ferdinando II de' Medici later developed alcohol thermometers sealed from the atmosphere, which prevented pressure changes from affecting the readings. In the late 1660s and 1700s, scientists started using alcohol, water, and later mercury as thermometric fluids, but there was still no universal temperature scale yet. Ole Romer lived in Denmark. He studied mathematics and astronomy at the University of Copenhagen. He was first employed by Louis XIV as a tutor for the heir to the French throne. In 1700, he persuaded the King of Denmark to introduce a Gregorian calendar. And around that time, he broke his leg, and while convalescing in bed, he developed one of the first thermometers. Romer invented a thermometer for measuring the temperature of wine. On his scale, 60 degrees was when water boiled, and 7.5 degrees was when ice melted. At that time, there was no standard temperature scale, and everybody made up his own. And finally, we get to Daniel Gabriel Fahrenheit. He was born in Germany in 1686. In 1701, when he was only 15 years old, his parents died from eating poisonous mushrooms. In 1717, he became a glass blower and was fascinated by natural science and new inventions such as the thermometer. In 1724, Fahrenheit modified Romer's design and scale and invented the new mercury thermometer with the Fahrenheit scale. He divided the freezing and boiling points of water into 180 degrees. Freezing point was defined as 32, boiling point 212. Zero was a temperature of an equal mixture of ice and water. And he found the normal human temperature was 96 degrees, which was later modified to 98.6 degrees. This is a photo of one of the original Fahrenheit thermometers. And in 2014, one of the three original Fahrenheit thermometers sold at a Christie's auction for over $100,000. You can see it looks like a modern thermometer. The world would be united today in measuring temperature in Fahrenheit degrees if it weren't for Anders Celsius. He was a Swedish astronomer, physicist, and mathematician who in 1742 introduced the Celsius scale, in which 100 degrees was defined as the freezing point and 0 degrees was defined as the boiling point of water at sea level. He died in 1744, and the next year, Carl Linnaeus, who is a famous botanist, reversed the scale and made 0 the freezing point and 100 degrees the boiling point of water at sea level. And in 1948, this was adopted by an international conference on weights and measures, and that's what most of the world uses today. Hermann Boerhaave was the first physician to put thermometer measurements to clinical practice. Incidentally, he was also the first to describe something called Boerhaave syndrome, which involves tearing of the esophagus, usually as a consequence of vigorous vomiting. 1724, he described the case of Baron Jan von Wassenaar, who was a Dutch admiral who died of this condition following a gluttonous feast and subsequent vomiting. The early medical thermometers were large and slow. Some took up to 20 minutes to measure a temperature. Sir Thomas Clifford Allbutt in 1867 invented a much smaller clinical thermometer that worked in about 5 minutes, and thermometry became integrated in medicine as a standard tool in diagnosing disease. Modern thermometers came about in the 20th century. In the 1950s, the ear thermometer was invented by the German physiologist Theodor Hans Benzinger at the U.S. Naval Medical and Research Institute. 1984, David Phillips invented the infrared ear thermometer. 1990s, Frank Pompey, who's an MIT trained engineer, developed and patented the temporal artery thermometer. And over the last 25 years, we've had various smart and wearable temperature sensors, wristbands, smartwatches, patches, adhesive rings, smart clothing, earbuds, or in-ear devices that can measure temperature. So returning to our main topic, what can cause fever in a dialysis patient? Number one cause of fever in a dialysis patient, of course, is infection. As I mentioned earlier, infection is the second most common cause of death in dialysis patients, and that's because they're relatively immunosuppressed. And they also have frequent potential exposure of blood to the environment because their blood passes through the tubing of the dialysis machine. Drugs can also cause fever, or people can have an allergic or hypersensitivity response to components of the dialysis circuit, such as the dialyzer. Uncommon causes are malignancy and connective tissue disease. There are many types of infections that can cause fever in dialysis patients. Most often, they are bacterial, and the most common cause of bacterial infections in dialysis patients include methicillin-resistant Staphylococcus aureus, as well as gram-negative rods. Viral infections, influenza, COVID, among others, can cause infection. Mycobacteria infections, including tuberculosis, occur at a frequency of 20 to 25-fold higher in dialysis patients than in the general population. There are 250 cases per 100,000 dialysis patients per year, and immigration from TB endemic countries is contributing to this problem. The number one risk factor for dialysis infection is the type of access. Catheter patients are much more likely to develop bacteria in the blood than those with a graft or fistula. In 2010 data suggested that bacteria in the blood was 7 times more likely with a catheter. Septicemia, which is defined as the presence of bacteria in the blood plus symptoms, is 3 times more likely among patients with a dialysis catheter. The key point that I want you to remember from not only this slide but from the whole talk is that fever in a dialysis patient with a catheter is a catheter infection until proven otherwise. So I'll say it again. If you have a dialysis patient who's using a catheter for access and they have a fever, they need to be ruled out for catheter infection. Then again, if a dialysis patient with a catheter in particular just has shaking chills, which is known as rigors, they have a very high likelihood of having bacteria in the blood, particularly Staph aureus or a gram-negative rod bacterium. In one study, the presence of shaking chills or rigors predicted the presence of bacteria with a sensitivity of 50 to 60% and a specificity of 80 to 90%. Still, dialysis AV fistulas can become infected, and the major risk factor for infection of a dialysis fistula is the use of a cannulation technique called buttonhole cannulation. This is defined as a cannulation method of the AV fistula using the exact same spot at the exact same angle and the same depth of penetration every time. And a scar tissue tunnel tract develops, allowing the eventual use of a buttonhole fistula needle, which is blunt or dull. The risk factors for fistula infection were looked at in a study by Charmaine Locke, who's a nephrologist in Toronto, Canada. It's a prospective cohort study of 630 dialysis patients between 2001 and 2010 in Toronto, Canada. And there were 3 types of patients: those who dialyzed in center, all of whom use a cannulation technique called rope ladder, where you vary the cannulation site. There was no self-cannulation. And then patients who dialyzed at home, all of whom did self-cannulation. Some of whom did short daily dialysis and others did nocturnal dialysis. This graph here shows the distribution of cannulation types. Everyone in center used rope ladder cannulation, whereas a lot of people who dialyze at home use buttonhole technique. What she found was that among patients who use the rope ladder technique of cannulation, there was maybe one possible fistula infection in center and none in the home group. Whereas those in the buttonhole group, there were 39 cases of bacteria in their blood, 85% of which were Staph aureus, or at least 2 local buttonhole site infections. 13% of the patients had to be hospitalized for infection, and 10% of the patients had serious metastatic infections. So what she concluded from this study was it's not the frequency of cannulation. I mean, there are patients who dialyze almost every day at home, but they, as long as they use a rope ladder cannulation technique, they didn't get bacteremia. It's not self-cannulation because all of the home hemodialysis patients who used rope ladder technique and were self-cannulators did not get infections. It wasn't dialysis location, it wasn't dialyzing in center or dialyzing at home that explained the infection risk. It's the buttonhole technique. So it's one of the reasons why we discourage the use of buttonhole cannulation in our dialysis units. Patients can also have fever independent of infection. For example, a drug fever is a fever that occurs as an adverse reaction to a medication without underlying infection. It is, of course, a diagnosis of exclusion. Most of these are due to hypersensitivity reactions. A hypersensitivity reaction is an exaggerated or inappropriate immune response to a foreign substance known as an antigen that can cause tissue damage or disease. These reactions occur when the immune system responds too strongly or mistakenly targets the body's own tissues, and it usually presents with a rash, typically 7 to 10 days after starting the medication, but it can be almost immediate if the patient has previously received that drug and they have been previously sensitized. Common examples include penicillin, cephalosporin, such as cefazolin, which we use in our dialysis unit. Certain blood pressure medications can do it, including hydralazine. Anti-seizure medication, phenytoin, can do it. And often these patients have a high eosinophil count in their blood. Dialysis itself can also cause a fever. There are a couple of mechanisms by which this can happen. One, you can have what's called a pyrogenic reaction. That occurs when endotoxins or bacterial contamination occurs of the dialysate or water supply. People have a febrile response to that. But you can also have what's called a hypersensitivity reaction. This occurs when a patient is allergic to the materials used in the dialysis circuit. It could be the dialyzer membrane, particularly the old cellulose-based membranes. It could be the sterilizing agent, ethylene oxide. Could even be heparin. This is called a delayed type hypersensitivity reaction. There are 4 different types, type 1 or 3. It leads to the release of a chemical called histamine, and that activates your mast cells in your skin, so you get urticaria or hives. You can have fever, you can have low blood pressure, chest pain, and back pain. There are 2 types of hypersensitivity reaction. Type A is an anaphylactic reaction that occurs within a few minutes of starting dialysis, and that typically occurs in patients who already have preformed IgE antibodies against, most often, the ethylene oxide gas, which is used to sterilize the dialyzer. Or more commonly, you can have what's called a type B reaction. Symptoms are milder, typically occur within the first 30 minutes of starting dialysis, and are thought due to the activation of part of our immune system called the complement cascade after blood comes into contact with the dialysis membrane. These reactions are much more common with the old cellulose membranes. These days, we used synthetic polymer dialysis membranes. Much less common causes of fever in a dialysis patient include malignancy. The 5-year risk of a dialysis patient developing cancer is about 10%. It's much higher than the general population. And certain cancers occur with particular frequency, including renal cell carcinoma at a rate 4 times higher than the general population, and bladder cancer that occurs 1.5 times higher at a 1.5 times higher rate than the general population. The fever is mediated by the release of what we call pyrogenic cytokines or chemicals from the tumor cells: interleukin 1, interleukin 6, tumor necrosis factor, interferon gamma. And these cytokines act on the hypothalamic thermoregulatory center. They raise the body's temperature set point, and patients have a fever. Connective tissue disease can also cause fever by virtue of the immune system. Some people have certain autoimmune diseases such as lupus or vasculitis as the cause of their kidney failure. And in this setting, the immune cells can also release pro-inflammatory cytokines which mediate fever. Okay, part 3, the most important part of the talk: how do we manage a febrile dialysis patient? We have two jobs when we're working with a febrile dialysis patient. One is to manage the fever with antipyretics and consider cooling the dialysate. Second, we need to identify the underlying cause of the fever, whether it's infection or a drug or dialyzer reaction. Antipyretics or anti-fever medications include acetaminophen or Tylenol, as well as NSAIDs or non-steroidal anti-inflammatory drugs. Both are thought to reduce fever by inhibiting prostaglandin production, which is important hormone for allowing the hypothalamus to adjust the temperature set point. It's generally a good idea to reduce the dialysate temperature in a febrile dialysis patient. As an aside, dialysate cooling may also be helpful in minimizing intradialytic hypotension. There are a lot of patients who frequently have low blood pressure during dialysis, and cooling the dialysate is a trick that we use sometimes to help support their blood pressure. It causes vasoconstriction of blood vessels, and that increases the pressure inside of the blood vessel and may minimize the potential for hypotension related injury. For example, in a 2014 British study of 73 dialysis patients, half of the patients dialyzed at a temperature of 0.5 degrees Celsius below their core temperature, and the other half dialyzed at 37 degrees. And after a year, there was significantly more ischemic injury to the brain seen on MRI in the patients who dialyzed at the higher dialysate temperature. That said, everything in life has a purpose, including fever, and fever is part of the body's immune response to infection. Higher temperature increases white blood cell activity, enhances cytokine signaling and antibody production, inhibits bacterial and viral growth. And so reducing fever may reduce the immune cell efficiency and slow pathogen clearance. A study published by the Royal Society claims that fever suppression causes at least 1% more influenza cases of death, which would result in at least 700 extra deaths per year in the United States alone. That said, there are also several observational studies that have not shown any significant change in mortality when anti fever medications are given. Now, if a patient has a dialysis catheter in place, a fever represents a catheter infection until proven otherwise, so we should take this very seriously. We contact the nephrologist, obtain 2 sets of blood cultures, administer antibiotics, typically vancomycin, plus or minus some gram-negative rod coverage such as ceftazidime. Refer to the emergency department, ideally after dialysis, but if the blood pressure is low, say the systolic is less than 100, treatment should be stopped and the patient should be sent by medics to the ER. If the blood cultures start to be positive, the dialysis catheter needs to be removed and antibiotics administered until the blood cultures are sterile, and then the catheter can be replaced. Now, if the dialysis patient has a fever but does not have a catheter and blood cultures are negative and is receiving, say, antibiotics, you might suspect a drug reaction. Drug reaction typically occurs 7 to 10 days after first starting a drug, but it can occur much sooner if the patient has previously been exposed to the drug. It's common to have both rash and fever, and the fever typically resolves within 2 to 3 days after stopping the drug. So, it's a diagnosis of exclusion, but it's important to maintain suspicion for this if the cultures are negative. If you suspect that the fever represents a dialyzer reaction, which typically occurs either right after starting dialysis or within the first 30 minutes, then stop dialysis immediately, particularly if the reaction is severe. We administer supportive care, including anti-fever medications, oxygen IV fluids, of course, epinephrine if anaphylaxis. And going forward, we want to change the dialysis materials. Make sure you're using a synthetic membrane, a steam sterilized dialyzer, not one that's cleaned with ethylene oxide. Might need to consider different anticoagulant if they have been receiving heparin. Of course, you want to ensure dialysate quality, use ultra pure water, and obviously sterile technique. And then you have to still investigate for the possibility of infection and consider empirically treating while waiting for blood culture results. Time to summarize what we've learned today. Fever is defined as an elevated body temperature caused by a regulated upward shift in the body's internal set point, which is controlled by the hypothalamus. Its purpose is to fight infection, slow the growth of pathogens, and enhance the body's immune system. Fever is very common, constituting 30% of healthcare visits by children, 75% of adults who are seriously ill, and 5% of emergency department visits. The first thermometers were invented in the 1600s, but they were not clinically useful until a standardized temperature scale was used. Boerhaave was the first physician to put thermometer use into clinical practice. Causes of fever in a dialysis patient include infection, drugs, hypersensitivity response to dialysis circuit, malignancy, and connective tissue disease. Bacterial infections are usually related to the dialysis access, most commonly seen in catheters, followed by grafts, and then finally fistulas. A dialysis patient with a fever and a catheter has a catheter infection until proven otherwise. And the major risk factor for a dialysis fistula infection is the use of the buttonhole cannulation technique. Drug fever can occur secondary to antibiotics and many other medications. Fever can also occur due to a hypersensitivity reaction to the dialysis circuit, particularly the dialysis membrane. Other causes include malignancy and connective tissue disease. Management includes Tylenol, cooling of the dialysate, refer to the hospital if they have a catheter in place. Suspected dialysis reaction is treated with alteration of the dialysis circuit, in particular using a different dialyzer. Time for the monthly quiz. Question number 1. Who invented the first modern thermometer? That's correct. It's B. Daniel Gabriel Fahrenheit. Question number 2. Fever in a dialysis patient can be caused by all of the following except. That's correct. All except for teething. Question number 3. A patient develops a fever and itching skin 30 minutes into dialysis. You suspect A, type A dialyzer reaction, a B, a type B dialyzer reaction, or C, tuberculosis. Excellent. So this is a good example of a type B dialyzer reaction. Question number 4. The risk of kidney cancer in dialysis patients is how much higher than in the general population? That's right, D, 4 times higher, and malignancy can cause fever in a dialysis patient. Final question. Acetaminophen and non-steroidal anti-inflammatory drugs reduce fever by what mechanism? That's correct. The answer is A, inhibition of the COX enzyme. And this concludes the December 2025 edition of the Northwest Kidney Center Monthly In Service. Thank you so much for your attention. Thank you for taking care of our patients. Merry Christmas, Happy Hanukkah, Happy New Year, Happy Holidays to everyone. Take care.